I walk into the room. I want to care, but I've been trained slowly over time to equate comprehensive care with what does the plan pay for? Full refraction? Done. Quick retinal image? Yeah, I'll do that. A product handoff because that's how I make my money? Yep, we'll do that. The patient might have a family history of macular degeneration. They might have borderline intraocular pressure, elevated intraocular pressures. They might have headaches at the end of the day after being on a computer all day long, burning eyes. But if I don't have time to address those things or it doesn't fit the plan, then I can easily push it aside. Why? Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today I want to talk about our approach to patients and how different payers have shaped the way we approach our patients, how they've got us focused on something totally different than what we really want to do for people, and try to help us understand why our behaviors are kind of matching what somebody else wants for us, and kind of expose that friction. And a lot of times I think, and we've been dealing with this within our own state association in Nebraska, within our legislative team, trying to articulate the problems that we see within managed vision care, but also we need to be reactive to, or we need to think about how we've been reactive to try to acquiesce to what the managed vision care plans have done, and take a broader approach to what medicine is doing and how medicine is being impacted. Because right now we see the managed vision care plans as being the real challenge, but I'll tell you that challenge, solving the problem of the reduced fee from managed vision care plans, is not solved unless we acknowledge that it's not solved by increasing that fee even to medical standards. And so I hear a lot of times people will talk about converting patients to medical as the solution, but I will tell you that even in medicine, that's not the solution. They cannot figure out how to simply take care of the patient again. And I want to talk about that. The other thing, though, before we get started is, we've been working a lot. I was hoping that I would have a lot more time to actually sit down with people and discuss their perspectives as well. At the beginning of this year, I haven't been able to do that. We've been working within Practice Performance Partners to really streamline and develop new things so that our users can access things better. So one of the things that we're really excited about in Q1 that will be rolled out is what's called a single sign-on. So you'll have access to your compliance app, you'll have access to education, you'll have access to CodeSafe Plus, all through one dashboard. The other thing that I'm really excited about is we're implementing, for those of you who have HR compliance, you'll have access to time clocks, which will allow people to request time off. It'll allow people to track within QuickBooks and sort of send that information in, which will be awesome. And then the other thing that's really cool is you'll be able to onboard and offboard all of your different team members seamlessly, so you can track the progress of somebody that you want to make sure that they're educated on their their billing habits, or educated on their optician training, so you can see their progress in real time. So that's going to be super exciting. We should have all of that available within Q1. And then we'll have a lot more things in Q2 that we're developing. And so I've been taking a lot of my time to help make sure the user experience within those systems translates very well. So in any case, I'm sorry you're going to hear another monologue. I hope you enjoy it. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding, so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Not all omega-3s are created equal, and we switched to TG Omegas because the triglyceride form offers superior bioavailability, and patients actually stay on it. For dry eye management, it's one of the few supplements we feel there's a clinically improved benefit for those patients. Smoother tear film with fewer symptoms. It's an easy upgrade to the standard omega-3 conversation, so check out TG3 for your patients and your practice. All right, so today I want to talk about something we all wrestle with, and I do mean all of us. I do mean myself as well. You know, when I'm in clinic, when I run my practice, I still see the same stuff. And it's this illusion of the comprehensive eye exam. And I want to unpack that term and how that has become to what it means underneath managed vision care, and how it's shaped the way we think, how we schedule, how we bill, and then really ultimately how we care for patients. And I want to use a story from Alex Berenson, who I have been following over the last 6 years. He's an author, he's a journalist, and I want to reflect on that story and think about how it translates into what we experience. So he recently described a primary care visit where a doctor did all the system approved things, primarily focusing on blood pressure and a vaccine checklist. But he ignored a very real personal concern that was sitting in front of him. And, it wasn't medicine, it was performance. And when I read that, I couldn't help but think, we're doing the same things in eye care. And so I wanted to talk about that. And I think the same things we're doing maybe don't apply to blood pressure, and they don't apply to vaccines, but they definitely apply to, what a payer wants us to focus on. So I want to give you a brief overview of the story. Alex Berenson walks into a modern corporate medical office, a few quick vitals, blood pressure that's flagged, vaccines suggested, but no exam of his drop foot. No mention of his recent tick bite, no questions about his back surgery. All of it was in his chart because that clinic, who had, hundreds of doctors running through that using the same EHR system, cared for all those different things, but none of it was discussed with him. And he left that visit feeling like he'd been processed, not cared for. And actually, he even reflected back on his previous doctor, who was an old doctor. And I wonder about myself in this too. I wonder, am I not my dad in all the wrong ways? He wondered about his, and by the way, my practice, I'm going to use in another analogy, but my dad always did a good job of trying to keep the practice updated. But, the picture that he painted, that Alex painted from his visits previously with his medical doctor, was he saw this guy for his entire adult life. He's in his 50s, probably 10 years older than me. He's probably 55. And he had seen his previous doctor was probably 80 years old, and he had seen them for the last 20 years. And, he would go in there, he would undress, he would check his vitals, he would talk to him like a person. His chart notes were scribbles on a piece of paper, no EHR. I just envisioned the optometric clinic with old phoropters and wood paneling on the walls. But the doctor sat down and listened to his concerns and addressed his concerns, not just checked the boxes. And so, he wrote that this new doctor that he went in, this big corporate entity, I think it happened to be Optum. He wrote that doctor wasn't a physician. He was a functionary treating a chart. Man, that's crazy. Like, I can find myself in that. I can find myself in that mode as a clinician and as a physician. Like, am I just checking boxes? Am I being reactive to what a payer wants me to do? Because certainly that doctor, was probably focused on those areas because he was being measured by those metrics. And so I want to be honest with myself. Like, how often does our comprehensive exam turn into the exact same thing? I walk into the room. I want to care, but I've been trained slowly over time to equate comprehensive care with what does the plan pay for? Full refraction? Done. Quick retinal image? Yeah, I'll do that. A product handoff because that's how I make my money? Yep, we'll do that. The patient might have a family history of macular degeneration. They might have borderline intraocular pressure, elevated intraocular pressures. They might have headaches at the end of the day after being on a computer all day long, burning eyes. But if I don't have time to address those things or it doesn't fit the plan, then I can easily push it aside. Why? Because I believe I've already done enough, right? I'll document those things. I'll address them. I gave the patient artificial tears. I recommended blue light filters. But, medical legally, I'm probably fine. I've done enough. But it's not really what the patient needs. It's not what they want, certainly. But it's a cognitive bias, right? We've convinced ourselves that the annual exam is complete care, when in reality, it's also often just the bare minimum that we need to do to be forced upon us by a system. So I want to think about how we got here. Most of us don't get paid fairly for the care we provide from these managed vision care plans. So what do? Right? We build a practice model that leans heavily into product sales, what I call high dollar widgets in order to survive. Eyewear packages, annual supplies, lens upgrades, add-ons that help us just break even. So, we're not trying to be salespeople. We don't want to be salespeople, but we're just trying to stay afloat. We're trying to care for the patients that are in front of us in a system that cares for what they purchase as opposed to what they need.
Presbyopic patients looking for a simple, comfortable daily option often do really well with Clarity One Day multifocals. We've had great success with it because the lens delivers stable vision at all distances and doesn't require complicated fitting strategies. In my practice, it's a reliable choice when we want something straightforward that still provides very good visual quality.
If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. So here's what creeps in over time, and it's subtle. The more pressure we feel to sell, the more we begin to tilt the whole exam toward that outcome. We start noticing the frame needs for a patient more than we notice optic nerve cupping. We think about blue light filter pitches instead of asking about screen time and headaches and doing a cover test and an NPC. Listen, I'm there with you. I think about this all the time, and it can creep in. We skip dry eye discussions because it slows us down and doesn't sell a pair of glasses. And then suddenly the plan has become the real patient, not the person in the chair. And that's what Berenson is experiencing as well. The system paid his doctor to check boxes, not to think, not to listen, not to touch, not to dive deeper. And it's happening to us. We're not bad doctors. We're just being shaped by bad incentives. Ophthalmology is the same thing. Ophthalmology is there checking boxes, making sure that the cataract surgeries that they do have satisfied the audit needs. Now they're focused on making sure that they discuss all the premium IOLs and that's how they're going to generate their revenue. I get it, right? It happens to all of us. But I want to think about what that looks like in the exam lane when we're actually managing patients. A patient comes in, we're running 15 minutes behind, and they say they're just here for their annual examination. So I'm really doing what they want. But we find out, we talk to them. Mom had macular degeneration. At the end of the day, they get headaches, right? Their eyes burn after taking their contact lenses out. And their pressures have crept up. Maybe it's not too high. Maybe it's 22, 23. What do? We nod. We maybe write something down or type into the chart. But the plan doesn't reimburse us for a dry eye consult at that visit, or real deep dive consult at that visit. We don't have time to go in for a glaucoma workup, so maybe we just get a screening OCT, or maybe we even bill the OCT to their medical insurance. But we got to get them to the optical and we can't delay that because that's what's going to cause that patient to not want to purchase from us. And, by the way, we've got other patients waiting in the next room. I feel this pressure. I'm there. We smile. We tell the patient, everything looks great. Don't worry about that stuff. We'll I've got a new prescription for you and head on to your way into the optical. We feel efficient, right? But deep down, we know we missed it, right? We missed an opportunity. Really, we missed the patient. We reflect on it and we get angry because we think that we should have been reimbursed more for that exam. And we really feel angry that we really couldn't dive into each one of those things separately. And that's what Berenson was trying to say. The doctor in the system never saw him. He just saw the system. He just saw the metrics that he needed to meet, the annual supply percentages, the revenue per refraction, the capture rate. And we're falling into the same pattern if we're not careful. You hear me talk a lot about KPIs, and those KPIs only matter because they're serving the patient that's in front of us based on prevalence data, not based on, some arbitrary mechanism for me to generate additional revenue from that patient. And so I think if I'm going to reflect on this, it's important for us to really take a step back and realize what's happening in this system. We have acquiesced to insurance. I won't even blame it on managed vision care plans. We've acquiesced to the insurance rigmarole, an insurance system that costs patients a whole lot of money even when they don't see us. They're frustrated with the insurance system, but we wind up becoming the bad guy because we're the outlet. We're the face in front of that patient that's there every day that they can get on the phone, right? Like they can get on the phone and they can gripe because of their uncertainty. They can get on the phone when their insurance company asks them or tells them that something's not covered. You get the patient, I had this just the other day, and it happens all the time. Patients that were on some medication for their ocular surface disease or for their glaucoma, and now all of a sudden that medication is going to cost them $400 a month. Well, they can't get their insurance company on the phone, and they can barely get the pharmacy on the phone. So who has to yield to that, right? It's us. It's not our fault that it costs $400 now and it cost $50 last time. It's not our fault that their plans have changed, but we're dealing with it. And so I want you to just take some time to just sit back and think about delivering care. How do I deliver care? How do I articulate the problems to patients? How do I empathize with them? I know a lot of you do a really great job of empathizing with that patient who's sitting in front of you. But how do I empathize with them in a way that allows me to deliver the care they need as opposed to what the check boxes are? And I think the closer we are, it's easier. It doesn't mean it's only done in these places, but it's easier when the doctor who is delivering the care is closest to the patient who understands those mechanisms and who understands the limitations on that level of care and really puts themselves in that patient's place. How do I care for you in a way that is meaningful to you and then also allows me to do what is necessary to deliver that care? The further that the doctor gets away from those processes and managing all those processes in the practice, the less likely it is to happen. That's where you see big conglomerates can make a determination on what's going to be valuable for a doctor, and then everything else flows from there. It doesn't mean the doctor's bad. It doesn't mean the doctor's wrong. It just means it's harder to control that level of care. So I want you to think about in your practice, how are you managing those patients who have all those concerns? Are you sitting down and talking with them about those concerns? Are you maybe setting aside another visit, some time for you to dive into those concerns specifically with the patient? I would encourage you to do it. If you haven't thought about scribes, so you can just actually walk into the patient, you know what's going on because you've read their chart thoroughly. You can ask your questions to your scribe about things that you need information on and just sit and talk to the patient that's sitting in front of you. Even if it's, diving deep, that's what they crave. They're craving that connection. I'll tell you, they're craving it. And we can be the ones to deliver it. And I actually believe we are the best place to deliver it. And I think it extends beyond, most people that are seeing family medicine doctors and internal medicine doctors are seeing them in association with large entities, large facilities, where the doctor is largely removed from the decisions that are going on within the business of that entity. And because of that, they're being forced just like we're being forced. And if we can resist that as a profession, and we can continue to deliver the care, the one-on-one, the face-to-face relationship with the patient, that'll benefit our communities, and it will certainly benefit the patients sitting in front of us. But we have to be able to resist it. We have to be able to identify those underlying things that impact us subconsciously, that force us to do the things that we don't really want to do, but we have to do in order to have our practice survive. So I would say, think about your comprehensive care. Think about how you're going to follow up with those patients. You've heard me talk time and time again about triggers, about follow-up, and the primary reason is so that we can focus on the patient in front of us. I hope this was helpful. I hope it was motivating to you. Please like and subscribe. Send this out if it was meaningful to you. Send it out to other people, and I will commit. I have some on the books already for some discussions I think you're going to find very valuable. Some people doing really cool things in the profession coming up very shortly. Have a great week. Talk to you soon.